Gavin. Is that okay?
That's why I prefer it.
So we can't. So Gavin can beat us up, and then we can't. And then we can't say anything.
That's
come on.
That's why I asked.
So that's why I'm gonna go on the offensive right away in my first slide.
Let's go. That's why I asked. I said I have to follow you guys. Remember, I may look stupid, but I'm not stupid.
You have 30 minutes to fight it off. Don't worry.
All right, so we are going live in 5, 4, 3, 2. Our webinar has started.
Iggy, I don't see the announcement at the bottom with the participants.
Which announcement, Parker?
I see it, John. There's 33 up 34 now.
Okay. I don't know why I don't see it, but that's okay.
Yeah.
Now there's 40. Yeah.
Okay, I'll wait 1 minute and I will get going. Okay, good evening, everybody. Welcome to our monthly episode of the University of Miami Cerebrovascular and Skull-Based Surgery Symposium. Always my favorite time of the month. This is our 43rd installment on April 21, 2022. And I'll introduce our speakers in a couple of minutes, but just to remind you, the co-directors of this course, my partners, Carolina Benjamin, Mike Ivan, Bobby Stark, and our steady panelist, my fellow David Altschuler, and our PG3 resident Eva Wu, who will show some cases in the last half hour of the talk. There is David, and there is Eva. Many thanks go, as we say every month, cannot thank them enough for the team behind the scenes that none of you see, but particularly Ignacio Escalona, who is running this webinar as always today. So my great pleasure today in having this topic, very important topic on cerebral aneurysm with clips, with flow diverters and web. We're going to have 3 spectacular speakers in the order in which they will speak. Is first Henry Wu. Henry is professor and vice president and director of the CV service at Northwell Health in Great Neck, New York. Henry will talk about an update on the combined use of flow diverter and web and what is, in his view, the future of endoluminal treatments. Pascal, my Lebanese compatriot and sommelier extraordinaire, level 3 or 4, I can't remember. He may have to tell us level 4, excuse me. Pascal going to talk about web for MCA aneurysms, appraisal of current techniques and results. Pascal is prof and division chief of neurovascular and endovascular surgery at Jefferson in Philadelphia. And last but not least, Gavin Britz is going to talk about MCA aneurysms. In his view, perhaps he will say that clipping is superior to web. We will see. He is chairman and director of the Houston Methodist Neurologic Institute and also holds professorship at Weill Cornell Medical College in Houston, Texas. All 3 of our speakers are duly trained microsurgeons and endovascular neurosurgeons, which is why, of course, this is a very relevant conversation. And if Henry ready? If Henry is ready, we can ask him to share his screen, unmute his microphone, and start his presentation. Henry, welcome and thanks.
Again, Jacques, thank you. This is a great forum that you have organized. Thank you for inviting me again to, give this topic, and to Gavin and to Pascal for joining as well. This was, I think, a little bit last minute, but obviously, Jacques, you were able to pull it off very, very easily and very quickly. So the topic that I was given was web and flow diversion for intracranial aneurysms. Obviously, I'm going to go through a little bit of history so that way we can go through how the evolution of this whole process has gone on. There have been, many adjunctive devices in addition to the introduction of the GDC coil in 1995 that have been utilized to address wide neck aneurysms. Obviously, I think everybody is very well familiar with balloon remodeling and stenting. And now I'm hoping that everybody is using the conglomerate mass coil technique with detachable coils that detach in 1 minute as opposed to 10 minutes. You can put in multiple coils and create a complex geometry prior to balloon deflation. But even before web and flow diversion, you were still able to take care of complex aneurysms like this, herniate the balloon into the other vessel and achieve coil masses and achieve occlusion and angiographic results like this. Aneurysms like this that were traditionally only in the venue of what we thought was surgical clipping when the efferent vessels come out at such an acute turn. Here is access into that inferior division where we have a loop-de-loop inside the aneurysm. There's a balloon straightening out the redundancy, the coil mass going into the aneurysm, and the balloon inflated so that way it protects not just that one vessel, but also the other vessel. And you can see the convex nature, concave nature, as opposed to the convex nature of the coil mass. The balloon allows you to create that geometric configuration such that the coils won't herniate down into the parent vessel. And there you have what it looks like immediately after the procedure. And that's what it looks like at 8 months. And these are durable procedures, in particular with endoluminal remodeling. Aneurysms like this, where the balloon is actually inflated inside the neck of the aneurysm, protecting it. That was a ruptured aneurysm. Even more complex aneurysms, you can see how acute the...
Hey, Henry,
yeah.
Sorry to interrupt you. There is a little crackling in the microphone. I don't know if it's yours or is something rubbing on your microphone.
Is that better?
On this, go for a while and let me see.
Okay. So you can see the really acute angle of both divisions of the MCA coming off this aneurysm. And so this aneurysm was treated with dual balloon remodeling, not just one balloon, because you can't herniate into the other vessel enough. And so these are the types of results that you can obtain even prior to web and to flow diversion. Why stenting also, we know, significantly enhances the durability of the endovascular treated aneurysm. And when I was at the clinic, we published the first case of this in our subsequent series. And we know that endoluminal remodeling alters the hemodynamics and alters the flow exchange, and also enables a barrier for the neointimal and the endothelium to grow across the aneurysm neck, enhancing the durability of the endovascularly treated aneurysms. And even back in 2011, we knew that these were the types of results that you could obtain with traditional balloon remodeling, coiling, and stent-assisted coiling. So now we have web. It is designed for bifurcation aneurysms, for anterior communicating artery aneurysms, middle cerebral artery aneurysms, as well as basilar apex aneurysms. And here, this middle cerebral artery aneurysm has all three branches, an anterior temporal branch, both superior and inferior divisions coming off of the base of the aneurysm. Traditionally, again, an aneurysm that would not be thought to be well treated with just traditional balloon remodeling, would certainly need dual balloon remodeling. But now, after web, this can be relatively straightforwardly treated. In addition to the web itself, we also have our access devices the Sophia, which basically can essentially track all the way into the M1 segment of the middle cerebral artery here. And this is the VIA microcatheter. And it can be just less than a centimeter away from the aneurysm itself. One of the other things, so again, here's the guide catheter in the M1 segment, the microcatheter. This is a 9x6 web, and you can see that it's clearly way too big and it's encroaching on the parent vessels. This is an 8x5 web, and you can see that it's clearly small, leaving a pretty significant residual. This is an 8x6 web, and that was eventually the final result. And this is the immediate post-procedural result, immediate post-deployment result. You can see the stagnation in the aneurysm and no limitation of flow into the middle cerebral vessels. This is the microdyna CT that is performed at the end of the procedure to really visualize the placement of the DFT nitinol platinum wires, because this is really the only way that you can truly visualize the placement of these fine mesh devices, and basically a coronal maximal intensity image looking at the web in this aneurysm. So even despite the 2 to 3 deployments, this case still only took about 45 minutes, and the patient left the day after the procedure. So this led us to say, hey, is there a better way that we can select the size of the web? So the traditional way that we determine what size web we are going to use is to take the height and the width and subtract, add 2 to the width, subtract 1 to 2 from the height. But we thought that, hey, there may be a better way using cone beam CT and the spatial resolution of cone beam CT to better identify and to determine the volume of the aneurysm itself. And so there is software that allows us to do this. It comes standard with any Siemens equipment, and we know the volume of the webs, of every single web. And so we can size not according to just height and width, but we can also size according to volume. And so we looked at our series and we plotted them against a regression analysis, and it was significantly statistically significant that using the web volume versus aneurysm volume was much better than just using the height and width measurements. And this was subsequently published in Interventional Neuroradiology based on our first, I think it was like 39 to 40 patients. This is the case. So moving on, this is the case where this idea and this concept of adding endoluminal remodeling to intrasaccular flow diversion came to mind. Look at this very wide neck anterior communicating artery aneurysm. Traditionally, no way to treat this type of aneurysm except for surgical clipping. This woman also had a son who had a ruptured anterior communicating artery aneurysm at the age of 21. And so after we deployed the first web, the web actually, because the aneurysm was so broad-based, the web actually flipped out of the aneurysm, even though we had a balloon from the left A1 into the right A2 to try to prevent that from occurring. The web has flipped completely upside down, and it's now occluding the contralateral A2. So I then I punctured the other groin, went from the right carotid to the contralateral A2, snared it with a microvenous snare, and I pulled that web out. So now we know that we need some form of endoluminal reconstruction for these types of cases. And here's the snare taking that web out. Here's what the angiogram looks like at the end of the procedure, where we went ahead and put a web in and basically extended across the anterior communicating complex. So that way there's now no way that the web can herniate out into the parent vessel. Again, another microdyna CT showing the relationship of the web to the stents. So there are also aneurysms like this. Again, no way to really protect that posterior communicating artery. Complex aneurysm, even doing it with surgical clipping, there's at least a 3 to 4 millimeter gap between the origin of that posterior communicating artery and the rest of the posterior cerebral artery. Very difficult to imagine how you're going to endoluminally remodel that vessel. This was treated with web and flow diversion and a pipeline. This is what it looks like prior to the procedure, and this is what it looks like on 1 month follow-up. And why do we get a 1 month follow-up visit on this particular aneurysm? Because she has a contralateral posterior communicating artery aneurysm that is very similar to this. So here you see the construct of the web and the flow diverter, which is basically right at the left internal carotid artery terminus. You can see that there's still a little bit of filling within the interstices of the web, but this is still at only 1 month follow-up with the patient on aspirin and Plavix. And here is the microdyna CT of the construct at the end of the procedure. You can see the distal and proximal portions of the web. And because of the orientation of this aneurysm, and because it's a sidewall aneurysm, you have to deploy the web with a significant amount of stress on it, which makes it a little bit more challenging as well. But you can see that the posterior communicating artery remains completely patent. I don't know why. Okay, here we go. This is the posterior communicating artery aneurysm on the other side, essentially very similar in concept to the left side. That's what it looks like at the end of the procedure in the AP and the lateral projections. And again, the microdyna CT. These are the coronal MIP projections, and on the right is again the volume rendered image showing preservation of the posterior communicating artery. We were able to land the flow diverter proximal to the terminus, and the web is perfectly placed to preserve that posterior communicating artery coming out of that lesion. Another type of aneurysm that now we can address endovascularly relatively straightforwardly. This aneurysm was actually clipped at my institution, not by me, but by someone else prior to my arrival. And this residual pericallosal aneurysm was left. You can see that there's a large anterior internal frontal, middle internal frontal, and a pericallosal branch that comes off of the distal A2 segment of the anterior cerebral artery. Look, it's obviously highly irregular. And so here is a microcatheter, the headway 21, in order to deliver a Fred Jr. This is a VIA 17. Now with the new VIA 17s, you can do a balloon remodeling type technique, because both the VIA 17 and a balloon or a stent or a headway 21 will be able to fit through an 071 or 072 system. You can see the clip, you can see the device as it flowers, and then as it flowers, we will push it towards the dome of the aneurysm while it is relatively compliant, so that way it doesn't rupture the aneurysm, obviously. And then now you're going to see the final aspect of the deployment. And then eventually we deploy the stent, and you can see the deformation. This is prior to deployment, and this is after the deployment, and you can see how it deforms the superior aspect of it. And the microdyna CT, the stent, the clip, and the web, and all of the vessels perfectly preserved. Wide-necked right middle cerebral artery aneurysm, again, previously treated with either dual balloon remodeling or clipping. This was treated with web and Y stenting with 2 Elvis Jr. stents. This is what it looks like immediately pre-procedure, and that is what it looks like at 6-month follow-up. And you can see that the aneurysm is completely gone. Another aneurysm, very similar. This was actually, this was also a Fred Jr. This aneurysm, we purposely deploy the flow diverter so that the working length would be just across the neck of the aneurysm, but that the total length where it does not have the braid would jail either the M1 or potentially the contralateral, the inferior division of that middle cerebral artery. And you can see that it's positioned in such a fashion that only the working portion is across the neck of the aneurysm. We have published also our results with the technical aspects of combined intrasaccular and endoluminal flow diversion. And we're working on another reprise of looking at our data. I think we now have something like close to 100 cases. These were the cases as of 2021, the Northwell Webb and Fred experience, looking at Webb and Fred. The new thing now is coded technology, and there are now coded stents. Pipeline is now coated with this phosphorylcholine shield. FredX and FredX Junior is now coated with this PMEA and also the Elvis. They also have the Elvis Junior, but they're going to wait for Evo in order for the PME device, in order for those devices to be also PMEA coated, and HPC, which is the flow diverter that is going to be introduced hopefully at some point in the United States by Phenox. The idea of these devices is the idea with these coded devices, although the data is not out there yet, is that it may obviate the need to put the patients on dual antiplatelet therapy on both aspirin and Plavix, and hopefully you will be able to get away with just aspirin alone. And if that occurs, it will significantly change and expand the armamentarium of aneurysms that are amenable for both intrasaccular and endoluminal remodeling. No question, every single month, something for intracranial aneurysms is coming out. The technology is continuing to improve, in particular for endovascular therapies in the treatment of these lesions. And even aneurysms that were previously only thought to be treated with surgical clipping or bypass can be safely treated with outstanding safety and efficacy results with overnight hospital stays. Thank you.
Thanks, Henry. That was number one, under the time allotted to you, which is unbelievable. Fantastic. Thank you. And very, very nice, impressive cases. We don't usually do questions between the speakers, but one of the audience members, Dr. Mahmoud, wants you to clarify how you preserved the PCOM artery, I think in the first case. Can you re-explain how you saved the PCOM artery?
That is by, so you're only going to jail the portion of the aneurysm where the PCOM originates from. How you save it depends upon how you size the Webb device. And that is also where the volume measurements really allow you to refine which size device that you need. So that way you can deploy just one device, make sure that it's large enough to take as much of the volume of the aneurysm that you want, and then subsequently small enough so that way the endoluminal flow diversion is only jailing just the origin of the PCOM.
Okay, great. I think we'll move to Pascal. Pascal, if you could stop sharing yours. Yeah, perfect. And mute your microphone. Henry, something, I don't know what's wrong with your speaker. It was a little crackly.
Sorry about that.
No, that's okay. But your voice and diction are so clear. It didn't matter, you know.
Thank you.
Pascal, talk to us about Webb device Panacea or just another tool.
All right. Can you see my slides?
Yes, sir.
All right. Thank you, Jacques, very much for the invitation. It's a great honor for me. I think what you did during those COVID times with those series of lectures is really unbelievable. And every single time you have at least hundreds of audience. So that's really great. So I'm going to be talking about the web device, and those are my disclosures. And more disclosures and background. I just want to say that we still clip more than 100 aneurysms a year at Jefferson. I never defend a tool. I defend an idea and a strategy. We are disease specialists, and this is what we should be, not tool specialists. And we are one of the few programs in the country that we have a CAST-approved combined fellowship in open vascular and endovascular fellowship. So I'm not biased here. And one last disclosure, and the most important one, is I love to fight dinosaurs. And dinosaurs come with different faces. Dinosaurs come with different, names. And I really love to do that. So evolution's gonna happen in life, no matter if we agree on it or not, it's gonna happen. And even Homer evoluted, maybe his body evoluted, but not his brain. And the same thing, the evolution in the neurovascular disease, you should think about it, as like all the tools available against the disease instead of competition and stuff. And one more disclosure, I forgot to say that I refuse to do debates about endovascular versus clipping. And it's just something, as you know, that's really gone years ago. Now we need to be more open-minded and try to choose the best tool for the best case. So it's very important. It's in our hands. It's our responsibility to make that the evolution of neurovascular surgery to remain disease-oriented and not procedure-oriented. Disruptive innovation in neurovascular is something that's happening every single day. Disruptive innovation is a word that was described by a professor of business school in Harvard. And in this, he describes the process by which a product emerges into an existing market, typically from outside established market leaders, and then relentlessly displaces established competitors. Think about it. We're seeing this in neurovascular every day. And we need to get used to that. And we need to be able to embrace the wind of change and try to choose really the best technique available, because this is going to happen if we like it or not. What I'm going to be talking about is the web device. That's the device. That's the old one where it used to be a double, but now it's not double. It's just one cage. And that's practically how it looks like. And this was the WEBIT trial. And this led to the approval of the web device in the US. It was a trial led by Adam Arthur. And it all comes to if you want to train your mind and to agree on a new definition. Okay, so we're looking here at some definitions about complete occlusion, about residual neck, about the residual aneurysm, or about adequate occlusion. I know that, Jacques loves this to make fun of this. What does adequate occlusion mean? It's either you occluded or you're not occluded. So this is something, a debate we need really to look at, because we really don't know. I don't know what's the natural history of this. We're watching it and we're seeing. I mean, again, I would be a fool to try to argue durability of any endovascular technique, angiographic endovascular technique, against clipping. We all know that clipping is the most durable. But if you have this for like 5-10 years, I would argue with you that's not complete occlusion, but we didn't have a rupture. The patient did well, and this may be acceptable. So anyway, those were the results of, just a second. Oops, sorry. Jumped. Yeah. So no death within the 30 days, major stroke 0.68%, day 31 to 1 year, 0% major stroke, 0% major neurological death. This is from the WEBIT trial. And then complete occlusion 53.8%. Yeah, that's a bad number, right? But adequate occlusion is 84.6%, which is the complete occlusion with the neck remnant. And then aneurysm remnant 10.5%. The retreatment rate was 5.6%, 8 of 143 in the trial. And progressive occlusion, what happened to those patients that we followed from 6 months to a year? 91.5%, so 9.2% got better, 79.4% remained the same, and 11.5% got worse. So here we're falling into the durability of endovascular techniques. And until now, the only durable that can compete with clipping, the only durable endovascular technique is flow diversion, because we know that with flow diversion, once the aneurysm is gone, it's never coming back. So we cannot argue durability on intrasaccular devices yet. So I talked about this. So the retreatment in the WEBIT, it was coiling 1 out of 8, stent-assisted coiling 4 out of 8, and flow diversion 3 out of 8 patients. Then additional 6 patients underwent retreatment in the following 12 months. And the overall retreatment rate so far in the WEBIT was 9.8% or 14 out of 143. This was when it was published, it was the largest series of web device after FDA approval. We published this in a Journal of Neurosurgery, and this was from our paper about really sizing is key, and we didn't know this at the beginning. And now, initially, we used to say you should oversize the web device by 1 millimeter, where now you should, I would say, oversize it by at least 2 millimeter. The better, the more you oversize it, and it's not herniating in the parent vessel, the better you're going to have a good long-term result. And this here, we're talking about the corking the neck. I'll show you some cases. Corking the neck technique is regardless of what the shape of the aneurysm is. If you're able to put this web device at the neck and let it hug the wall and oversize it, regardless of the shape of the aneurysm, you're going to have a good result. Oversizing comes from some physics mainly. So here, if you look, if you don't oversize the web and you put some heavy weight on it, it's going to compress. If you oversize the web, it will hug, it will become stiffer, and then even with the weight, it won't compress. As you know, all the recurrence that we see, the majority of them, I'm going to show you, see the web all the way compressed completely. So this is a neutral position. This is under tension. This is so very important before you deploy the web to really evaluate your device to see in what category you are and if you need to do anything to it. This is our series for the paper we published February 2019 until 2021. 115 aneurysms treated with web, 34 subarachnoid hemorrhage, 81 unruptured, and majority were successful. We were able to deploy the web. Complication rate overall 5.5%, and we had 1 death. Contrast clearance, once you deploy the web, you see stasis. So we had stasis in the venous face in more than 50% of the time. We showed in another paper that this is correlated with the occlusion rate. So adequate occlusion was 86% in our series, and 5.5% required retreatment on follow-up angiogram. Some cases of MCA aneurysm, you see here, this is 1 year follow-up. You see the great results. Large MCA aneurysm, 1 year follow-up. You see those results. Same thing here. Same thing. And I can keep on showing you another case of a 8.4 millimeter MCA aneurysm. This is the deployment technique. So just important that before it opens up, it's very stiff. You need to be careful. And then after it opens, it softens. This is the DynaCT showing the web device. And this is the stasis of contrast you get after the deployment. And this is the 2 year follow-up angiogram showing a complete occlusion of the aneurysm. Corking the neck that I talked about, in case you have like an oblong aneurysm, this is an oblong aneurysm. All we needed to do is to just place the web at the neck. And here it is. We pulled it a little bit, and you see a complete occlusion automatically. Here it shows when we pulled it to occlude the neck. Another case here, the same case, showing that we're gonna pull it. We're gonna pull the device to bring it to the neck and make sure that it's occluding the neck. Another case of a corking the neck, as you see here, that's the PCOM aneurysm. So the web is just here, and that's the aneurysm here. It's all the way here. The web ends here, and you see all the stasis of contrast. This is another cork the neck. So when the aneurysm is oblong is when you really can do that. Another basilar tip aneurysm, you see here the web device deployed just at the neck in here, and then it thromboses and stasis of contrast up there. So predictors of aneurysm occlusion following the web treatment, this we published this in August of last year, where we looked at our own series and we looked at the literature at the same time. So a total between our series and the literature of 358 aneurysm, and contrast stasis on the post-deployment angiogram was significant predictor of aneurysm occlusion. Morphological characteristics such as wider neck, irregular shape, along smoking and hypertension can negatively impact the occlusion rate. When I talk about stasis, that's what I'm talking about. If you deploy a web and you have this, I mean, this is absolutely 100% occluded at 6 months, at a year even. So definitely. Web for ruptured aneurysm, is also a topic that's important, because those are the cases where if the patient is not a good candidate for clipping, you don't want to put the patient on dual antiplatelet therapy. Web would be a great device. This is actually, we published it in neurosurgery. It was the first series of ruptured web that was published at that time. And then after that, we contributed to many with a lot of collaborators about ruptured aneurysms treated with web. This is a large series, and I think Bobby Stark is on it also. So practically in this series, 94 ruptured intracranial aneurysms treated, successful deployment in 97.8%, 13.9% deaths, 1 had to be clipped, 3 stented, no rebleed or delayed rupture. And this is very important, that there was, when you're gonna treat a ruptured aneurysm with web, you need to make sure that there is no acute or long-term rebleed or delayed rupture. 80% adequate occlusion, and then 87% had favorable outcome, a modified Rankin scale less than 2 at 90 days. 4 had to be retreated during the follow-up. This is a case of a patient that presented with a ruptured aneurysm. She was 84 years old, grade 4 subarachnoid hemorrhage, had 2 aneurysms. It was a tough arch, couldn't go radial, couldn't go femoral, so decided to do a carotid stick. This is a case where she had a PCOM aneurysm. That was no problem. I was able to call it, but she had also an MCA aneurysm. Oh, sorry for this noise. Okay, she had a PCOM aneurysm and an MCA aneurysm. We were able to coil the PCOM aneurysm, and then for the MCA aneurysm, I think the web was perfect. We didn't have to stent her. We didn't have to do anything else. She wasn't a candidate for a clip, and then we did the web device for that, and then we ended up putting an angioseal to close the puncture site. So stent-assisted coiling versus web device for wide neck bifurcating aneurysm. This paper has just got accepted in Journal of Neurosurgery. It's going to come out soon. We looked at 150 cases and we compared stent-assisted coiling, Y stenting, and stent-assisted coiling for bifurcating aneurysms and web device. And it turned out that the web device is associated with a lower rate of neck remnant at 6 months and 12 months compared to stent-assisted coiling. The web was also associated with fewer complication rate and decreased retreatment rate as compared to stent-assisted coiling. We've all heard when we first start using web, it's like, oh, what do you do with the recurrences? We've seen from Europe recurrences at the dome of the aneurysm, and you can't treat them well. This is a paper we just published about retreatment strategies of web recurrence. And you have different retreatment strategies. It depends on each aneurysm. One of them is just clipping, and turned out that clipping a webbed aneurysm is actually not as bad as clipping a previously coiled aneurysm. You don't have to worry about removing. Sometimes if you don't have enough room, you need to remove the neck, open the aneurysm. This is when you increase the risk of the procedure. Well, in the case of web, I've clipped now at least 4 web recurrences. You can crush the web with your clip, and very easy. You don't have to do anything else. So this is the case of a PCOM that I treated with web. This was the stasis of contrast after the web deployment. And then this is the recurrence at 6 months follow-up angiogram. In this case, I decided to clip it. And this is the intra-op angiogram with a clip. This is a case of a patient that presented with a grade 4 subarachnoid hemorrhage at the same time with an MI. The patient had an ACOM aneurysm, so decided to treat it with a web, treated the patient with a web. This is the stasis of contrast, and then this is the web deployment here. I think looking at here, I could have compressed the web more and oversized it. Then the patient came in for 6 months follow-up angiogram, and there is this recurrence. As you see, the web is crushed here. Again, I mean, this guy had an MI. He was a high grade. When the patient presented, I don't think I would have I would have done a favor if I went and clipped him. We treated the aneurysm, and then we brought him back at 6 months, and then we decided to treat him electively. In this case, what I did is I enrolled the patient in the contour trial, and that's a contour device. You see here the stasis of contrast after the contour is deployed. The contour device, I'll show you some cases later on. This is a case, a patient on Eliquis for AFib with coronary artery disease presented with this distal M1 or M1, M2 aneurysm. I decided to treat this patient with a web device. Very important to see some technical aspects here. The via, when the via is not centered, the via is the microcatheter. You need to really deploy the device completely and pull on it until it opens up. If you're not centered in the aneurysm, but be careful that this is stiff still. And then as you see here, when I release it, it's gonna open up. This is the device once it's when it's opened completely, and you see here the detachment. I'm gonna detach it. You see it's gonna flip, and here it is. It's detached. This is the immediate result, which was in my eyes, it was acceptable result. But then the patient came back with a recurrence. Look at the device. Look at the device here. So in general, whenever we do a follow-up angiogram on a web device, I try to do a bet with my fellows. Before we shoot the angiogram, I tell them do just a single shot, and let's look at the shape of the device, of the web. And then I can tell them, like, we're gonna find a recurrence here or not before even we shoot the dye. So practically whenever you see a picture like that, I can bet you 100% you're gonna have a recurrence. Why is this happening? I mean, multiple theories. One of them is you didn't oversize enough and it's being compressed, like cold compaction. And then another theory is like clot retraction, and it's retracting the clot, and it's doing that. So in this case, I decided to treat the patient with Y stenting and coiling, and here it is. We were able to, that's the device crushed, those are the coils, Y stenting, and here it is at 1 year follow-up angiogram. Again, as I said, in durability, we can't, it's not like flow diversion. We can't replicate the flow diversion model for durability yet, because with flow diversion, we know, and we showed here, that once your aneurysm is gone, it's gone. You don't have to keep on following the aneurysm if at 6 months you have 100% occlusion. You need to really understand the different phases of the web deployment. You need to know that at the beginning, this is very stiff, and this is stiffer than anything we've ever placed in an aneurysm before. And this is important. And we've learned that I've learned it the hard way. Once it starts to flare up, this is when it becomes soft. And then at the end, you can push it like what Henry showed. You deploy it, you push it in the aneurysm. It takes the shape of the aneurysm. It's safe to do it because it's really soft. So here, when it's at this phase, this is like a harpoon. It's going to puncture the aneurysm even worse. Once it goes puncture the aneurysm, it's going to open up. And this is when you have a big hole in the dome. Those are rupture. Thankfully, we don't have a lot. I had only one rupture with this, but those ruptures are really bad because once it opens up, it pokes a big hole in the dome. This is a case in ACOM where that's what happened. The web device opened up and then created a big hole in the aneurysm. As soon as I did another run, no flow to the brain, no blood flow. I've never seen this. It was the blood flow, the bleed was so strong that completely no more blood flow to the brain. We had to place 2 ventricles right away on the INR table. I had to quickly call the aneurysm, but the patient didn't do well, and then the family ended up withdrawing care. So this is an unfortunate case of rupture with a web device. So just in general, some people will start teasing us that you know, if you do if you do both, you cannot be good at both, or if you're a dually trained aneurysm, you cannot be a good clipper. Well, you know, this is a paper that was written by one of my previous fellow, Kimon Bekalis, when he looked at the Medicare database of patients that were clipped by only open surgeons versus aneurysms clipped by dually trained neurosurgeons, and looked at the outcome, 1 year mortality, 30-day readmission, discharge to rehab, length of stay, everything was the same. So yes, we can do both. So for people that are not happy there's web, well, I have good news for you. There are so many other devices coming up, and this is one of them. That's the Contour device. As you can see here, it's a plug at the neck. And this is how it looks like, creating stasis in the aneurysm. There's now a trial in the US. I'm the national PI with Demetrius Lopez, and we've enrolled now, I think, around 40 cases in the country. This is a case of an MCA aneurysm that I treated with the Contour device. So that's the aneurysm here. You see the device being brought here, and then we're deploying the device, we're unsheathing it. And then that's the run showing complete state. You don't even see contrast there. And that's the DynaCT showing the stasis of contrast. And that's here the device, how it looks like. That's the DynaCT. Again, we don't have follow-ups yet. It's still too early. I can't tell about durability, but this is a device that has its indications. This is one of the indications. This is a patient that was coiled for a ruptured aneurysm many years ago, 10 years ago, came in with this recurrence. Initially, I put her on the schedule for clipping. Then, you know, I decided to enroll her in the Contour device. And this is the device here. And this is the device. And you see here the run before and the run after. You see stasis of contrast and no filling here. We still need to wait for the follow-up angiogram to see. But when you don't have room, when you have recurrences of a web, when you have a recurrence of previously coiled aneurysm where there's no room other than just placing this device, I think this would be the real indication for the Contour device, is to go and place this plug at the neck in there. Another intrasaccular device, which is the Citadel or the Trenza device with Citadel trial. It's like a leaflets, if you look here, like a leaflets of coil. And what's really important in this trial, this is the first trial that is first in human in the US. We're all used to, you know, devices where our European friends will be making fun of us, like, oh, you guys are happy with the web, we've been doing web for the last 5-10 years, or you guys are happy with pipeline, we've been using pipeline. Well, this is the first device where it's first in human in the US feasibility study. That's really good. And Ansar Rai is the PI. This is a patient that was clipped 5 years ago, and then had a big either recurrence or de novo on the other side. Probably the MCA bifurcation was diseased. The patient had an intra-op angiogram showing complete occlusion, but 5 years later is that. So obviously the patient had already clips there, and I think going back to try to clip it would be high risk. So this is practically the device. It creates the basket, and then after you place one device, at that time you would coil the aneurysm, and the coils will stay inside. So if you see here, you see how wide are those leaflets. And this is after you place one Trenza device, you see the stasis of contrast in the aneurysm just after one device. And then here you see the coils, and the coils really will stay. I mean, if you look back at this aneurysm, I'm showing you really the takeoff of the M2 is really high in the aneurysm. So I really wanted something to keep the coils away from this takeoff of the M2. And then this is a DynaCT after the deployment of the Trenza before coiling. You see the contrast stasis, and then you see those leaflets, how wide are those coils and how they look like. And this is the final result. So I want to conclude and say, don't bash disruptive innovation, right? By definition, disruptive innovation is going to disrupt what you have been doing for years. That's not a reason to bash it. It's one more tool against the disease. Web has its limitation, definitely, and it's not here to replace surgery. It's just a complement for some cases where surgery is not the best option. Stay open-minded, as I said, embrace the wind of change, and patient selection is key. One final thought, as I said earlier, you can never argue angiographic durability of an endovascular technique compared to clipping. And I'm saying angiographic durability. It doesn't mean if you have a small remnant, it means this definitely we need to treat the picture and go crazy and try to have a perfect picture. But in general, angiographic durability, we all know that, yeah, clipping is the gold standard. Again, I mean, I think if you watch my lectures, you're bored of this slide, but I always like to mention it because it's exactly like matching.com. It's like dating, you and your device or your new device. You get to know each other, like dating. You get to anticipate the reaction to your action. You get to learn to avoid embarrassing situations. You get to know how much to ask and what to expect from your device and from your date, the same. And you need to avoid pushing to a nervous breakdown. And remember, some wounds are not repairable. I showed you one of them earlier, and and then try to learn from our mistakes. It's really important to auto-criticize ourselves, have the insight, and then learn from the mistakes. This sheep, was saved, and then right away, same thing, jumped in again. Everything we do is a team sport. I'm very grateful to be working with great partners, with my mentor, Dr. Rosenwasser. Everyone knows her as my work wife, Stav, Reed, Nabil, all our partners. We're a great team. I can't do any of this without them. And if you think that we do crazy things at Jefferson, well, wait until you see this. We have a horse that comes and visits patients in the hospital. It's not a pony, it's a mini horse. So you'd be rounding, you see a horse visiting patients. So thank you very much.
Thank you, Pascal. And of course, your lectures are always colorful. By the way, without the essence of dinosaurs, there would be no word, Where do you think fossil fuel comes from? Without dinosaurs, you cannot survive. So thank God for dinosaurs. I'm very proud to be one.
Well, let me add something. We all stand on shoulders of dinosaurs. Okay.
Make sure you don't get on their claws. Let me see if there is any burning question. No, we'll cover some of those questions later. Thank you. Gavin, go ahead.
Yeah, I'm ready. Thanks, Jock. First of all, thanks for inviting me. And obviously, it's a pleasure to talk against Henry and Pascal. I think my talks can be a little less, not as long as theirs, because I don't need to make it long. Can we share my screen?
Yeah, you can do it.
Yeah, I can see it. Okay, hold on. Okay, so what I'm going to talk about today is, obviously, I'm going to be dogmatic. I'm a dinosaur. I do first of all, unlike Pascal and Henry are sitting with their ties, I've already done an acoustic this morning, followed by a Fred flow diverter, and I'm waiting to do a shunt offer. So that's why I'm in my scrubs, and the pontificators, Henry and Pascal, are sitting there in their bow ties. But I think as Jocks and myself talk about, we have to be honest. I agree. I'm a dual trained neurosurgeon, as I said today, acoustic and followed by flow diversion. But I truly think we need to look at the devices. So as we develop them, we need to be sure what we're doing and what's best for the patient. Hold on, why is it on? Okay. So I think, first of all, we need to understand what is a web device. I think, as Pascal and Henry both said, a web is an endo bridge. And I think the operative word is a bridge. And we look at this picture that Pascal showed, it's a bridge, but we look at this bridge, it's not going anywhere, okay? And if you look at the bridge below that, it's like what we call a bridge to nowhere. So I think that we have to look at the web device as something that's not really going anywhere. It truly is a bridge to nowhere. And I always teach my residents that words have meaning. And, what is a bridge to nowhere? It's a bridge that there's 5 main origins. The bridge was never completed. one or both edges of the bridge collapsed, have been destroyed. It's no longer used. The streets are not built. And I think the other situation is where there's a lot of pork barrel spending and it's of negligible public usefulness. I think that's what this means. But I'm going to give Pascal and Henry some credit. I don't think they are correct. It's not a bridge to nowhere. They are smarter than this sometimes. It's a bridge to retreatment and retreatment and retreatment and failure. And it actually reminds me of one of the definitions of a bridge to nowhere. And looking at both their cases, so I'm glad afterwards, how many of those cases where there was stented coiling after that was failure devices? So I think that's the thing you have to look about it, is that this device is an evolution, but currently I think the web is a bridge to retreatment and failure. So I think when I look at it as more from a scientific perspective, we all want to push the fields forward. We don't want to be dogmatic that endovascular is not the future. But I think as Pascal mentioned, I think the difference between clipping and the web is the three major factors. I think you look at this image below, clipping does pull the endothelium together. The shape is less important because you can do a clipping, you can do a clip reconstruction. And I think there's a low incidence of residual aneurysms at the size appropriate for a web device. I think as we know that we treat web aneurysms from 3 millimeters to 10 millimeters, and most MC aneurysms, for most surgeons, we can get a pretty good reconstruction for MC aneurysms in a clipping. The web, by definition, keeps the endothelium apart. The aneurysm shape is not the shape of the web, and therefore it does predispose to endoleaks. I do believe in the capping and all the oversizing of the web does decrease it, but still, it's not the perfect scenario to get a complete occlusion of the aneurysm. But most importantly, it's almost like a bridge to having some failure, because we always have residual at the base. Even in the best scenarios that both Pascal and Henry have shown, there is that neck remnant. And if you have a neck remnant with a device that's keeping the neck open, you are no doubt going to have a residual. As I said before, this is going to be a shorter talk than the other two, but I'm unbiased. And I just look at it when I look at my patients, and in my practice, I do clipping and coiling a lot. I'm not a big web user because I have to treat the resins how to clip, and I think the other guys do a lot of web. But I'm just going to show you the data, and the data will speak for themselves. Unlike Pascal, them showed their own data, I'm going to just show other people's data. If you look at the long-term outcomes of the web device for treatment of wide neck bifurcation aneurysms, in a short follow-up of 15 months, 78% had a complete occlusion in the last follow-up. 1 in 5 of the aneurysms required retreatment, and the treatment was not without risk. It's 4.4% morbidity, although there's a low mortality. But if you're going to retreat and retreat and retreat these patients, your morbidity is going to go up. And look at the slide. Look at the slide here. We've talked about it. Following day, 72%, but at midterm results and long-term results, just over 50% of patients have complete occlusion. So about 40% of people have residual neck. And I remember from the days, and Pascal and Henry will talk about it, when we coil the aneurysms, we believe we treat the dome, but a lot of us believe that the risk of rupture gets transferred from the dome to the base of the aneurysm. And already we know that at least 2% of aneurysms rupture from the base. And if we're going to transfer that base from the top of the dome to the base, I think some of these patients long-term are going to rupture. And I think a device must be safe, but it also has to be effective. And when I look at this device myself, with just a 40% complete occlusion, or not a conclusion, I'd be worried about how safe this device is long-term. I think as Pascal showed, looking at the Adam Arthur study, at 12 months, again, 53% of complete occlusion. And I don't care what people say, some of those patients are going to re-rupture over long-term follow-up. And obviously, a jog feels like I do. What is adequate occlusion? I think when you look at the definition of aneurysm surgery, the goal of an aneurysm surgeon is to exclude the aneurysm from the circulation and preserve the parent vessels and preserve the perforators. That's the goal. When you go into an operation, it mustn't be to get there to get adequate results like Henry likes to do, but it's there to get a complete occlusion of the aneurysm. And when you look at these two major studies, even with Pascal's data, We don't have a device. We will have a device. I'm not against endovascular therapy, but I do believe the web device is not the answer at the current time. Obviously, I'm going to just talk about specific results. When you look at complete obliteration of aneurysms, it's at least 96%. If I have to give my data, it's over 90% of complete obliteration of an aneurysm with a clipping group. And when you look at retreatment rates, it's 4%, but those are only the ones with residual aneurysm. If you take a patient with a clipped aneurysm, clipped aneurysm with no residual, the incidence of reoccurrence of these aneurysms is in the 0.1% or 0.2% per year. So this is truly a durable treatment that is there to stay for now. When you look at the durability and risk factors of aneurysm recurrence of the clipping again, as I mentioned earlier, even a different group, Aaron Goodell's group, 8% of patients had residual, and of those again, post-clipping with no residual, a very, very low recurrence rate. And the ones that occur are the ones that have some residual. But again, this is the gold standard. This is what we need to compare all the new and modern endovascular devices to. When you go to middle cerebral aneurysms, this is again the Barrett trial. It looks like it's a little different results, but post-op, 87% occlusion, 3-year, 88, and 6-year, 95. A lot of these were retreatments, but also a lot of the crossover studies. But again, shows even for long-term, we have a treatment modality that is pretty safe and pretty effective. We look at outcomes. In that study, again, a different author to make sure I'm not showing my results. In our study, Clipper resulted in a 0.8% mortality and a 3% permanent morbidity. If you look at even the best results with the web device, that's just 2 treatments. 2 retreatments, you're going to have a morbidity. So again, when you're comparing the new devices, we've got to develop these new devices, but you have to understand that this is the gold standard. When you look at, this is actually a paper I just found last night, and I think this sums up a lot of the talk. I think this is a retrospective review and a meta-analysis from, again, different authors. I don't even know these authors that looked at the French studies, the webcast 2, and the French observatory study, and they compared the web versus microsurgical clipping for a wide-necked brain aneurysms. And when they analyzed it, they could not even show a superiority of the web in terms of mortality, morbidity, and change in MRS association in unruptured aneurysms. So therefore, again, proves what particularly Jock and myself understand, clipping is a pretty safe procedure. And they posed the question of whether a web should even be presented as a viable option comparable to alternative patients to amenable to surgical therapy. And this is, again, just a clear example. I know Pascal showed his great results that showed 100% occlusion of his web devices, but this is the reality. This is what the people in the community and people that have less skill than Pascal and Henry will have. That's a nice MCA aneurysm. The web device is well placed. Look at the date, 2019. An angiogram again, 2021. A complete recurrence. And we know, as all of us as dual-trained neurosurgeons, if this is an easy one to clip, so what we've done for this patient, we placed a web with a morbidity of at least 2%, and now we've got to go retreat her, and she ended up having a stenosis coiling, but without complications, but still, it's a retreatment. It puts the patient at risk. I'm not going to show you all my cases, but for us that do a lot of surgery, these are little small MC aneurysms. These go inside, go home, not the next day, Pascal, but the following day, routine intraoperative angios. And I think if you're doing a lot of aneurysms, using intraoperative angio, our morbidity of these patients is less than 2% for unruptured aneurysms. So I think this is still the standard of care that we need to do. I think that when you look at all the MC aneurysm series, that's all comers. And I think the web devices and the web series are almost skewed towards better results. Because as I mentioned earlier, the web device is not really approved for giant aneurysms, although in my job, I see second opinions from people that have had webs on big aneurysms and they've all reoccurred. But the surgical trial was all comers. So the results I showed you or even includes large aneurysms, where you guys showing the web devices have a success rate of about 60%, and that includes the most perfect aneurysms for surgical clipping. So another, this example of, one of the other cases I did, MC aneurysm, giant aneurysm, multiple clips, that's the post-op, that's a post-op scan. And again, showing Homer Simpson at Pascal said, for the large MC aneurysms, this is exactly how I would look at the web at the web device. Okay, this is what it is. So I think the web device has to be very, very, utilized in a very specific fashion in a research trial, rather than using what many people are doing all over the country at the moment. And my best advice for the web device is the web device should be placed and then placed in the jaws of an alligator retrieval device and then pulled out. Because otherwise, what you're going to have every year is going to be, morning, Dr. Pascal, morning, Dr. Wu, I'm here for my yearly treatment of my MC aneurysm. And and I mean, this is a funny slide, but it's really true. I think that when you look at the people that, I'm in Texas, and people are crazy here, they do anything and everything, and we'll see a lot of things happening with the devices, the endoscopic devices, that are not good for patients. So for me, I think for most people, this is the take-home slide. It deserves to be on the table rather than on patients. I think in conclusion, as I said, this is going to be a small talk. We'll discuss it. I think that MC aneurysms, I think, should be the standard of care in clipping based on the results. I'm not biased. I do it both ways. I believe in the endovascular future, but I think that all the endovascular photoversion devices should be only done in trials and in large centers. And this will allow the expected growth in the field of endovascular surgery, but I still think we need to know that this is a standard of care is for MCA clipping. For most people that come inside there, they should be clipped. Unfortunately, what I see, if you only have one tool and only one hammer, that's what patients are going to get. And I don't think in Texas that patients get offered both the clipping and the clipping and the coiling. And I also want to congratulate Henry and Pascal on their new book that's just available on Amazon. And I think, Jock, I'll send you a copy. But I think this sums up the talk. We have to be thoughtful. We have to think about what we're doing. Clipping MC aneurysm anyone can do, but we've really got to understand our patients, what their needs are, and it shouldn't just be a novel device to get a new paper out. And I think me and Pascal talked about earlier, this is where I spend my time when I'm not in the OR, which is not very often. That's my farm, that's my horses, that's my hay fields. And Jacques, Pascal, and Henry, unlike you guys with the bow ties, I actually do all the work myself. That's my tractor, that's my toolcat, that's my horses, and I do work. So I'm actually a blue-collar neurosurgeon, and my faculty will tell you 600 to 800 cases a year, operate 5 days a week, no bow tie, no saber for the champagne. But I really believe that I think, the endovascular is the future. There's no doubt about it. But we have to understand that we got to present patients with both options. And I truly see it in Texas here that a lot of the times the patients are not being given both options. They say, this is what the new device is. It's a safer. But truly, if you have a device that's got a 40% failure in a young person, I think they should be clipped. Thanks, Jock. I mean, it's a short talk because MCA clipping, what do you talk about? Just it's a better procedure, and that's where we need to go.
Thank you very much. As I promised the audience, entertainment as well as state-of-the-art presentations, and I think they got it. And that's what the best we can ask for. So before we start showing you cases, maybe any...
I have one comment,
ahead, Pascal,
to Gavin. Gavin, you as a surgeon, you should, I thought you would pay attention to details. You misspelled my name. You put double L at the end. I thought,
Oh yeah, that's true. Yeah, but Pascal, I'm so busy running around to the OR. I didn't adjust Pascal. My bow tie. I never adjusted my bow tie properly for you. So Pascal, I said,
yeah,
that is just emblematic of how he clips aneurysms.
Yeah.
Well, anything else? Anybody wants to talk about anything before we tackle some of the audience questions?
Just one more thing, Gavin. Let's say for patients with wide neck aneurysms and bifurcating aneurysms that are not candidate for clipping, don't you think that if we are able to treat them with a technique to avoid dual antiplatelet therapy and avoid putting metal in the parent vessel, wouldn't be a good thing?
So let me answer that in two questions. First of all, you said not amenable to clipping. So I think as Jock and myself say, well, you must be very specific. What's not amenable to clipping? So when we talk about,
let's say we all know that you're not gonna clip someone like I showed with an acute MI with a subarachnoid hemorrhage that just came in, or someone that has it's a high grade with multiple medical problems and comorbidities, and 85-year-old patient. So I'm not saying not amenable from a physical standpoint. I'm saying that the comorbidities make them a higher risk category for clipping.
No, I completely agree with you. I think in certain situations, the web devices improve. The problem is that what I'm seeing, and I'm sure Jock sees it as well, people extrapolate those cases into a 22-year-old with an MCA aneurysm. So I think that, do I think a web device is not the future, or not the web device itself, but do I think that endosaccular flow diversion is not going to be the future? No, completely believe that. But Pascal, Mike, and I really believe this, what I'm saying now, I think that, you guys, Adam, Arthur, that are really interested in this should be pushing the fields, but a lot of these cases should be placed into trials. Every case that has a web device or endosaccular device should be part of a registry or trial, so we can really look at the data. What I'm seeing though is that someone comes in, they don't clip, so what, it gets a web or it gets a stent-assisted coiling, and that's my problem with the field. I think that we've got to worry about, what the motivation is. If you have one tool, that's what you're going to do. But I think that like that patient you described with an 85-year-old, that's a heart attack, absolutely, because the web will get them through that. We do even myself, someone comes in with that's sick, I'll do subtotal coiling even. I'm not going to go clip the patient, I'm going to do subtotal coiling, knowingly I want to get the patient through the next 2-3 weeks, and then I'll either go clip it or go do a flow diverter or a stent-assisted coiling. But the problem is, and this I worry about with companies, I think it's, and the surgeons themselves, we're driven by not just say the wrong motivation, the motives, but probably not the most pure motives. And that's the thing about it. So I think, I'm for flow diversion. I said, I just did one after the acoustic this morning, but I think that we have to be introspective. It's our job for society and for science as we lead the field to be honest and say, what will we want for ourselves? And I know for myself, if I have an MC aneurysm that's like 7 millimeters, even at my age, and I'm getting older now, I want it clipped, okay? When I'm 95, riding my horses and I have a subarachnoid, I'll call Pascal or Henry to come put their web device. But I think we have to be honest in how we approach this disease process.
Yeah, totally agree. And by the way, Gavin, I'll be happy to come and proctor you for your web cases. Let me know anytime, and then I'll go visit the horses and everything.
When you come to the boot camp,
He'll bring wine and champagne with him. That'll be a very high quality.
Yeah, I know it'll be high quality.
Okay, let me invite Eva. Eva, could you share your slide and show the first case, and then we can do David, and then back to Eva again to show the last case.
Okay, can you see my screen, Dr. Morcos?
Yes, we can.
Okay, so yeah, thank you to all the experts for their amazing talks. They're really good.
Eva, were you entertained by the back and forth between those big names?
I was.
Yes. How about that? Go ahead.
But yeah, and then thanks, Dr. Morcos, for giving me this opportunity to present this case. And so our first case is a 68-year-old female who actually presented to another hospital initially with thunderclap headaches. She had no other relevant past medical history, and she was neuro intact on exam. And on this CT scan, it showed this small amount of blood in the right sylvian fissure and then in right MCA aneurysm. And so then 2 hours later, she actually started vomiting, became unresponsive. And then now on exam, she was localizing in the right upper, withdrawing in the left upper and bilateral lowers. And so they repeated the CT scan, which showed that this aneurysm had re-ruptured, and there was now more blood in the basal cisterns, more eccentric to the right. And so then she was intubated, EVD was placed, and she was transferred to our institution for management. And so here's the lateral right ECA injection, and then this is a lateral right ICA injection. This is an AP ICA injection, and then a slightly different view. And so in a second, I'm going to ask the panelists to describe, how would they describe this aneurysm. So just so the panelists can see.
Eva, if you can, just for the audience also, put your mouse on where the aneurysm is. I don't know if you can.
Yeah, so it's
Yeah.
right
Just,
here.
yeah, like circle
Yeah,
the
please,
area.
can you show Gavin where the aneurysm is?
Yeah, exactly.
So here, okay, and so this is and so then I'll just show one more view, and then we'll ask our experts how they would describe it.
Let's ask them in the order, I guess, that they spoke. Henry, what interpret for us what's going on here?
This is a partially thrombosed, fusiform dissecting type aneurysm. The entire blood vessel wall is diseased. There's definitely thrombus. This is only the endoluminal filling portion of the aneurysm. The aneurysm is almost certainly significantly larger, and that superior division of the middle cerebral artery is going into the frontal operculum of the right hemisphere. So that is the disease pathology. If you want to talk about treatment.
Yeah, Eva, do you have to show them any other picture?
No, that's it. Yeah, that's it.
This is it. Yeah. Okay. Go ahead, Henry.
So the treatment options here are parent vessel sacrifice and bypass. In the acute setting, it becomes much more difficult. When I have been using bypass, I've been using navigation with augmented reality to identify the STA and identify the definitive recipient vessels, so that way we can ensure that we are in the right place. If you are going to do bypass in the acute setting, which I don't think is such a great idea, you can also clip proximally the aneurysm at the same time. It doesn't look like the aneurysm is so big that you are not going to be able to get proximal control. If you can't see that superior division coming off the M1, you can always occlude the parent vessel endovascularly. There's no good coil or web strategy for this aneurysm. One other potential treatment that you can consider for this aneurysm is pipeline shield or Fred Jr. They do Fred X Juniors. They come in a they come down to 2.5 millimeters. This is probably like a 1.5 millimeter vessel, but basically they are also coated and try to get by the subarachnoid hemorrhage with the coated stents on aspirin alone, or the other option is aspirin and cangrelor. If the patient bleeds again a little bit, you can take them off the cangrelor, so that way the P2Y12 effect is reduced immediately. But I think that those are the issues. Huntington has grade 4. I think surgical a surgical approach to this thing is difficult to do.
So what would you do? Sorry, Henry. So what would you do at your institution on day one that she arrives, if you're faced with this patient today?
I think that we would probably parent vessel sacrifice. It's only a superior division right,
yes, right,
middle cerebral artery, parent vessel sacrifice. And, yes, she may end up having a stroke, but she is Huntington grade 4, but then you have definitively secured the aneurysm. When she goes into vasospasm, you're going to be able to treat that vasospasm effectively. I think that that's probably the most straightforward way of treating it. If you want to get cute, you can try flow diverting it and crossing your fingers that the flow diversion will protect her from hemorrhage and that it's not going to clot off. And if it clots off, it's going to basically have affected the result that you would have done by doing a parent vessel sacrifice of the aneurysm.
Pascal, anything to add, to disagree with? What would you say?
No, I mean, I agree with the description of a dissecting partially thrombosed. From a surgical standpoint, I need to look at more pictures, but I think reimplantation is an option, or side to side. It depends how close the vessels are. But if you distally, it seems that you may be able to reimplant distally or do side to side.
Don't you think that all that clot is right in that circular component of it? And so
Yeah, I'm saying
it's pretty far away.
distally to it. You have
No, but getting the distal and the proximal segments together, they're pretty far away.
no. I'm not saying to.
He's talking about
and
implanting it.
I'm not
in-
saying end to end. I'm saying go distally and transect and reimplant this end to side or side to side. I'm not saying that to do end to end here. Those you don't have. I have my arrow here. You don't see it. I'm not saying that. I'm saying just go distally to the aneurysm and then reimplant. Anyway, I mean, with flow diversion here, it's going to be a high risk of thrombosis. It's a very small vessel and it's a little bit tricky. I would add something. If I decide to do a deconstructive procedure, I can do provocative testing. I can do a super selective run, get the microcatheter in this vessel, and then do amital and lidocaine. We do all our cases under neurophysiologic monitoring. I mean, it's not,
You think that's reliable enough?
sensitivity. Well, it is reliable. It's not, I think it's give you some sense of security. We do all our cases under neurophysiologic monitoring, and I think this would be an option before deconstructing the vessels.
So Pascal, again, for the audience who's mostly young people who are not, experts endovascular, tell them the endovascular limitations are related to size of the vessel.
The endovascular limitations here are the multiple things. You have to put the patient on dual antiplatelet therapy, a patient that's an acute subarachnoid hemorrhage with all the risks that this carries. The size of the vessel is very small, so higher risk of thrombosing the flow diverter. I agree with Henry. I would go with a Fred, because the Fred, you can use a small microcatheter in case you decide to do that. You can go with a 21 microcatheter. But yeah, the size of it, the fact that it's acute, and that's mainly the limitation of that. Yeah.
Gavin,
Eva, can you put the 3D up? I'm going to just prove these two guys wrong again. So anyway, for the young audience, okay. So when I look at this aneurysm, stop right there. Just stop there.
Okay.
So for the young audience, this is a dissecting aneurysm clearly, and I'll tell you why. When you find discrepancies, so look at that's the inferior trunk, but look at that vessel size, and then it enlarges. Okay, by default, that is an unstable, very unstable aneurysm. That is a dissecting aneurysm, and this is exactly why these people rebled. And I love telling Henry he's wrong. And for me, a dissecting aneurysm, there's no ways I will put a flow diverter, because we know a flow diverter is not a complete cure straight away. I think that for me, when I find a dissecting aneurysm, I've got to not have what Pascal and Henry like describing about an adequate treatment, okay? We want what Jacques and myself to like to do as a complete treatment. And it's jokes aside, I think this is a clearly dissecting aneurysm, and these things are very unstable. You've got to treat them. So our options were, if Orlando and Richard are radiologists on call, I can guarantee you they'll take a microcatheter and they will just do a coil sacrifice for $400 rather than the very expensive flow diverter that Henry and Pascal will do, and the patient will rebleed and die. For me, personally, if I'm on call, I think that the coil sacrifice is an option. I think you look at the data from France, you can take an M1 and 20% of people only have a stroke. But I really think you can find the distal branch for that. It's small. I'd expose it, and I would do an end to side distally for this aneurysm. I was on call, but I guarantee you for the radiologist, it would be a coil occlusion. But I think for the young faculty, for the young residents, when you see the discrepancy in size, this is a dissecting aneurysm, she's going to re-rupture, and I wouldn't put it over for the weekend. Even if she comes on Saturday, I would do it that same weekend, because she's going to re-bleed and she's going to die.
Okay, fake news. Okay, be aware, everyone. And Bobby, I would like Bobby to give his opinion, because we've published with Bobby, and he's published so much. If there's anything really an indication for flow diverter, not for this aneurysm, but in general, Gavin, you seem like dissecting ruptured aneurysm is a no-no for flow diversion.
No. But this one, we're talking about this one.
No, this
said,
one.
We said
this one, I agree. This one, I agree. But in general,
some flow diverted dissecting aneurysms, you find a little bit of a lumen, then you can do a flow diverted like a PCA. I've done that before.
Fine.
But this one, where there's a massive discrepancy,
I agree, but I thought, yes, but I thought you said originally, you said, this is a dissecting ruptured aneurysm, absolutely no flow diverter in general.
But this one, when you find a PCA, Jock, I thought he had the champagne after the talk, not before the talk.
Bobby, I want you to talk. I want Bobby to talk about his paper on treating dissecting aneurysms with flow diversion. Please, Bobby.
Yeah, I mean, I think for some dissecting aneurysms, flow diverting.
Bobby, you're too far from the microphone. Get closer to your,
Is that better?
A little better, yeah. It's a little muffled.
I can try and speak up, but I mean, I agree for certain dissecting aneurysms, flow diverting stents are a great option. You know, I agree with the presenters here. You know, this is definitely a tough case. Someone who's Hun has 4, if you do a bypass, you know, you have a reasonable chance of spasm. So in someone who's a grade 4, I'd probably do provocative testing and consider just sacrificing that segment. I agree. It's frontal operculum. It's probably on the right side, going to be well tolerated. You know, Hun has 1, Hun has 2 with less blood. I think bypass, a very good option.
Eva, tell them what we did.
Yeah, so what we ended up doing, you know, the panelists, they all brought up really excellent points, and we considered some of those approaches when we were deciding on our own, but we ended up deciding to do a trap and bypass using either M2 to M2 bypass or temporal vein interpositional graft or STA to MCA bypass. And we also had vascular surgery on standby to harvest the saphenous vein if we needed, because her bilateral radial arteries were thrombosed. And so this is after we did a cranial-orbital approach with an orbital bar osteotomy. And so I'm going to skip some of this video.
Did Bobby thrombose her radial artery with his transradial angiogram?
Of course.
But yeah, so we dissected the distal frontal and temporal M2. And so because both the M2 vessels were pretty close together, we thought that doing a side-to-side bypass would probably work after the aneurysm was trapped. And so here we do this bypass. And I'll fast forward through some of this again. And so we do a running along the back, and then a running stitch along the front as well. And so now after the bypass, we place a proximal clip on the aneurysm.
And there was room to do it. Going back to Henry's point, we were able to trap it, you know, completely. It wasn't a huge aneurysm.
Mm-hmm. And so then here's the distal clip. And so then we did an ICG actually afterwards. And so the ICG, it shows that the aneurysm's patent, and then the aneurysm was occluded.
You know, what I want to discuss is what Eva hasn't mentioned. I did not do this acutely. I actually waited a few days. I put the patient on Amicar, and because I did not want the patient to go into vasospasm with the bypass, and then you risk 2 territories. So I did this several days after the presentation. Of course, the risk was she could have rebled in the meantime. But, you know, can you... you know, you could argue that's not a good strategy, but I got away with it. But is there any reason to use Amicar today for any cases whatsoever? I guess not. I haven't used one in a long time.
So, Jock, first of all, for me, the dissecting aneurysm, I mean, you were lucky to get away with it because she's rebled twice already. She rebled again. And the third thing, you know, for Amicar, I've used it, but very seldom. And if I'm going to do a bypass, there's no ways I'll use Amicar, because Amicar is going to make, I think it'll increase the chance of clotting. So I would not, you know, when I do the bypass, I use gel, you know, as Surgicel, all that over, but, you know, bypass, I don't do anything like that. because of prothrombotic states, but I would be careful of Amicar with a bypass.
Yeah, I stopped it. Well, not whatever it's worth.
What's the half-life?
2 days.
What's the half-life? I don't know.
It's pretty short. I mean, we published a study looking at Amicar used acutely up until definitive treatment, and we found there was slightly decreased rebleeding, but there is increased prothrombotic complications. And in the modern era, I mean, we're treating most ruptured aneurysms acutely right when they come in or the first day. So, the chances of having an acute problem are much lower. Obviously, if you leave them on for more than 3 days, your vasospasm risk also significantly increases with Amicar and tranexamic acid.
Yeah, and really, this you wanted to show the case. I mean, besides showing the microsurgical aspects of dealing these difficult aneurysms, is there are of course cases today that really don't have a good, easy endovascular option, and which is why we need to have young, people qualified to treat those things surgically. But yeah, she did as well as you'd expect. Grade 4, didn't get worse from the treatment, and was left with significant deficits from the subarachnoid hemorrhage. No strokes in the distribution of these vessels. Okay, David.
Yes, thank you, Dr. Morcos, and thank you again to the panelists. I'll share a case that has some similarities, though also some subtle nuances and differences. And I've given away a little bit what we did here, but this is a 41-year-old patient that presented with acute headaches and gait imbalance and hemiesthesia on the right side. No deficits on exam. And on her MRI at a local emergency room, she had a lateral medullary stroke.
Wallenberg syndrome.
Here's her vascular imaging, 3D reconstructions of her angiogram, showing a pica aneurysm. And I'll pause it here before we proceed to the surgical treatment that we selected, and panelists can discuss what they would do.
Let's start with Gavin this time. Gavin, this is not a rupture. This is a thrombotic, again, dissecting, non-ruptured proximal pica aneurysm resulting in a Wallenberg. Number one, should we treat? Should we put her on antiplatelets or anticoagulation and not treat surgically or endovascularly?
No, so anyway, so Jock, as you said, go back to that image. As you can see, this is clearly, as I showed you earlier, discrepancy of the size of the caliber of the vessel. This is a dissecting aneurysm of the pica. So for her, she's had a stroke, and she probably had a stroke, when she dissected, and I think that stroke is done. Any cerebellar stroke as well, Jock, or just the Wallenberg stroke? No,
just the Wallenberg. And she saw me 5 weeks after the event. She was perfect clinically when I saw her.
So for me, I'd want to really look at the vert, on both picas. I think the issue here is that she's actually, if you look at that angiogram, even though there's minimal flow into that pica. So I'd want to look what the other pica looks like to get an idea what the collaterals is as well. And I think that then it would be a decision that I would do with her. I think that Orlando and Richard, again, my radiology guys, if they saw this patient, they would look at the other pica on the I see on the left side, and this looks like a pretty, I don't know what size the pica on the other side is.
It's very similar size.
Similar size. Okay, so those ones I would tell the patient, but they would say just sacrifice it, because I think it's going to, well, you could try a flow divert if you can try and get through it. But I just, when I look at this little this lumen, it's really small. And I think it's going to be risky, but I think someone like Orlando could probably get through that and put a flow diverter there. As I said, but I would, for myself, I look at this, I say to either going to just go and sacrifice it, or I do a pica bypass. If this pica was a smaller one and the other one was a larger one, I would just sacrifice it with a coil, which will take you 10 minutes. But I think for me, I'd tell her, look, this is a situation, we can do end-to-end distal pica bypass and then occlude it, and you should be fine. But I think, Jocko, this situation, there's many options that are correct. I think that much like Pascal said, it depends on the wife, the match, what you're comfortable with. I think that people like you and I who do a lot of bypasses, I think a bypass is a very good option. I think for someone that's in a small community that that sees the same patient, I think an attempt at an endovascular option with a simple sacrifice may get she may actually do okay because she's had her Wallenberg stroke already, or they can do a flow diverter. But for me, I would sacrifice and do an end-to-end pica because I'm sure if she's got an equally large pica, we can do a distal anastomosis.
Kevin, if you're going to do a bypass, why would you do a side-to-side pica bypass and threaten the other pica territory?
And the reason being, it's just easier to do. Henry, you always try and do something that's going to work. You don't want to go try a proximal bypass. I think if you look at Mike may try and do a direct implant.
There's so much redundancy to the pica.
Show me the film. Run it.
There's so much redundancy to the pica, and look at the way that the left vert, like
go back to the
above, and so
or you could do an end-to-end, but I still think it's going to be, Henry, it's going to be harder than you think to do an
end to side proximal pica. Look at the redundancy in the pica, end to side into the proximal vert. And also, although it looks like there is a luminal discrepancy, and it appears that there is a stenosis, I bet you the actual vessel is much larger.
No, I agree there, but it still looks. There's no question.
I agree.
So you argue this is not a dissection, Henry?
I think this is a partial. I think this is also a partially thrombosed dissecting aneurysm that took a perf. That's why the patient has a Wallenberg and a lateral medullary syndrome. Can you go back to the angiogram? Go back. Do you have digital subtraction angiography?
Sorry, no, just the 3D reconstruction.
The other thing too about the 3D is that it does also overestimate the degree of stenosis to some degree. But you have tremendous redundancy here in the pica, and so if you are going to do a surgical treatment, I think end to side the proximal pica to that segment of the vertebral artery where you could potentially cut it from. And you don't have to do it right at the origin of the pica. You can just occlude it with a clip, and then you can pick where in the vertebral artery it is closer to the surface, so that way you can do your end to side to the vertebral artery at that level.
Now, Andrew, I agree with you, but I'd want to look at the CTA, look at very carefully to see exactly where the vert is. Because when you look at this image, and I'm sure Jacques will tell you, it's going to be misleading. Sometimes it looks like, it's a very superficial vertebral artery. You can quickly do the plug-in. Sometimes it's very misleading. So you'd have to really look at the CTA to see exactly where you get. But I'm not arguing with you. I think you can do that. But I think for me, when I look at this, and also what I try and do often is do a dual injection, inject both verts, and truly see what's going on. So you can see how close the picas are together. I think it's one thing Orlando has taught us a lot here at Methodist is that doing dual injections, check both verts at the same time, and then really evaluate both picas and do that. I think it's a valid option.
That vert is the dominant vert. That left vert is the dominant vert. The right vert is hypoplastic, and you can see on the 3D.
I know, but I'm just telling you
all the way back down to the.
But I'm telling you, in general, it helps. It really helps when you do a nice 3D ray with a dual injection.
How is injection of the hypoplastic right vert going to help you visualize an aneurysm?
No, I'm not saying
the left pica that is proximal.
Henry, you must be drinking as well. In general, getting a dual injection for ACOMs and vertebral makes a big difference. Not saying this case.
I agree with. There are cases
Henry, when you listen to details, I think the more information you have. So before I'll do any of this cases, I'd want to get a really good high quality CTA. Look at this. Look at the anatomy, the bony anatomy. I will do a dual run just to get as much information as I can. Because unlike the radiologist that you are, we want to really approach this as a surgical operation and understand the anatomy well.
I think looking at the 2D here is very important. We need the 2D because like what Henry said, the 3D can overestimate the stenosis, but the stenosis looks very bad here. If we look at the 2D and try to look how all the territories are filling, because this patient, I'm not sure if maybe this patient wasn't filling antegrade his pica, maybe there was distally some collateral, and the pica has been filling retrograde in a way, like the 2D.
No, it was antegrade. It was antegrade.
Okay.
Sorry, we don't. And by the way, sorry to interrupt you, Pascal, because actually I'm delighted to see that my colleague, Dr. Ali Malik, who's an excellent endovascular physician, who actually sent me the case. He's on the. I can see him. He just wrote a message here. She said he said she was, which I knew, he was neurologically intact, and it was not felt that the flow diverter would allow for the flow to remain optimal. We felt that bypass was a better option.
That's I mean, here, even like Gavin was saying, maybe deconstruct the vessel. But if this stenosis is real, I don't know how you can even get a microcatheter there. And then it's going to be risky, because if you're going to push your microcatheter, you're just there at the dissection and you may have a re-rupture. If we're going to talk, and I'm not saying that's the right thing to do, I think you treated it elegantly and that's the right thing to do. If we're going to talk endovascular, I think one other option we should discuss is, because already there's such severe stenosis, if you place a flow diverter in the vertebral artery, we've seen cases with perforator aneurysms where you decrease the flow much that it will thrombose slowly. Not sure, looking at this, it's a really severe stenosis. It could, that's why I want to look at the 2D. It could be that just a flow diverter in the vertebral artery, not in the pica, can also slowly thrombose that.
Pascal, to tell you the truth, I was in Bogota at the World Congress, and somebody showed, I can't remember who, somebody showed exactly what you said, a flow diverter in the vert that resulted in a remodeling and a perfect angiographic result of a pica aneurysm several millimeters away into the pica. So it certainly could happen. The problem is predictability.
You're right. We only do this, and we've published one of them in those dissecting basilar tip perforator aneurysms. You know, sometimes you have like a posterior fossa hemorrhage, you do your angiogram, you see a wisp in the perforator of the basilar of a tiny aneurysm. And those, the majority, you repeat the angiogram in 3-4 days, they are thrombosed anyway. But we've had a couple of cases where we just placed a short flow diverter in the basilar artery and then it got thrombosed. Not sure if it was the natural history or the flow diverter, but.
I think one other thing about this case, I mean, I don't think it's relevant, but it's relevant for the last case. You know, I think the stenosis, you know, flow diversion into the pica, not a good one for this. But we do have a case series coming out of compassionate use for Silk Vista Baby, which goes through an 017, you know, tiny microcatheter. And we have a series for dissecting pica aneurysms where it's worked well. Again, I probably would not try and put a microcatheter into this one, but.
Okay. David, just quickly show again the surgical aspect. So in those cases, I always go in thinking I may have to use the occipital artery, I may have to reimplant, may have to do end-to-end. We did go ahead, David, sorry.
Yeah, far lateral approach, proximity of the contralateral pica to the ipsilateral pica distal to the aneurysm was favorable for a side-to-side bypass. And so this video is showing here the aneurysm. You can see
there is an important point. I don't know, David, if you can freeze it. There is a perforator that comes out immediately, like almost from the aneurysm, but just after it. Maybe so. I don't know if you edited it in the picture.
I think it is. I think it's a little further along when we actually clip.
So, Jock, I see the dinosaurs think alike. Eh? I think you're in good company of the dinosaurs.
Well, you know, if it works, why not?
That's exactly. Yeah, I think Henry's spending too much time in the restaurants in New York. He's not operating enough, Jock. That's his problem. He's going to the fine dining restaurants. That's the problem.
That's why I am
in Houston.
Henry, Gavin is jealous how you and me, we do double office cases, but we can still look elegant with our bow tie and ties.
Yes,
hey, Pascal, a diagnostic angio is not a case, okay, by the way.
What about ventrix? I do a lot of ventrix.
That's a case, yeah.
So we did the bypass. You can speed. Yeah. Okay. And now I did not trap the aneurysm. I only took it proximally because there was no room to put a distal clip because of the perforator. And I'm saying this because of the point that was made earlier. I don't know if you can freeze it when it shows. Do you have it, David? You know, there is a perforator, a medullary
Yes.
perforator. This is a proximal. That's easy.
This is proximal.
Yeah, right.
But Jacques,
yeah.
the patient already has a Wallenberg infarct.
Well, but I mean, she recovered clinically. But I don't know if this perforator that I'm seeing will result in the same area of previous infarction. So why risk it? So that, again, to remind the audience that proximal occlusion is enough in a case like this. I don't need to fully trap it, what I'm saying. And the angiogram, as you can imagine, will show a complete disappearance of the aneurysm and preservation of that perforator through reversal of flow. So again, a variant on trapping. So it's an incomplete trapping, but it works, again, to preserve perforators. But again, to tell you endovascularly occluding a vessel, I remember Bob Solomon used it in one of his papers, is not a point occlusion. You know, you have a certain distance of coils, or so only the clip really will provide you with a point occlusion of a vessel. Again, just another variation of that. Comments before we do the last case of Bobby? No? Okay. Eva, are you presenting Bobby's case?
Yeah, let me pull up the slides. Okay, so yeah, this is a case of Dr. Starks, and so it's a young patient who had an incidentally found aneurysm on workup for headaches, and so she actually went to 3 other major academic institutions before she came to our institution and decided on treatment. And so she was neuro intact, had no other relevant past medical history. And this is her MRI flare in T2 showing this partially thrombosed aneurysm. So we did an angiogram, and then this is an AP, and then a lateral view. And then this is the 3D rotational angiogram. And so here we see this is a left temporal M2 fusiform aneurysm with 1 inflow and then 1 outflow. And so we just wanted to ask the panelists, you know, what would they do in this situation? How would they manage the patient?
Pascal, you start. Pascal with 2 L's, you start.
That's right. So I think this is a case where, first of all, it's distal. It's an M2 aneurysm. We're far away from perforators. This is an aneurysm that has 1 inflow, 1 outflow. And I would do a flow diverter on this one. I would avoid trapping jailing any of the distal M2. So there is enough room to land it distally. And I land it proximally, I'll stay short, and that's what I would do.
Henry. Is Henry?
Yeah. I agree. This looks like you've got a really long distal landing zone and a really long proximal landing zone. It doesn't look like the distal efferent vessel is coming off at such a severe angle. You should be able to basically navigate relatively straightforwardly into it. Yes, no question. You can do bypass. We haven't seen the external injections. You can probably even just get away with like an STA bypass into one of those distal MCA vessels, but this natively reconstructs, endoluminally reconstructs a channel, a bypass inside the aneurysm. And depending upon how hard it is to cross the aneurysm, can be, it is about as straightforward conceptually as we can get. I would not coil it.
Gavin?
Yeah, so anyway, so this case reminds me of a case I treated about 9 months ago. And I said, well, and first of all, this lady's got a left-sided. This one, mine was right-sided. And talking about that first option of clip reconstruction. So she came maybe about a year ago. came inside with it and like that, and I did a clip reconstruction, and the angiogram looked really good. But what happened was she presented with a massive bleed about 6 months after that, and she had, you know, we and obviously we've done, John and myself, and we've done many of the big clip reconstructions fine, but this one reminds me of the one I clip reconstructed an aneurysm wall, and that thing just regrew, and she ruptured.
Don't
and
you think, Gavin, that the entire circumference of
no, I know, but Henry, I promise you, I've done it before and I've got away with it. But I tell you this now, the one I did not recent, but a year ago, I never got away with it. Because what happens is, much like Laplace's law, if you can narrow it down and reconstruct it, generally you get away with it.
This is like that other case where you're saying, hey, listen,
no,
flow divert it, and maybe the patient
Henry,
won't be bleeding again. I mean, like, this is, are you, so pathophysiology.
Henry, your butler's calling you. I know, I can hear the phone going. Your butler's calling you for lunch. But let me finish.
You're probably calling him. You're probably calling him to call me.
But I'm telling you, Henry, I'm saying to you, I made a mistake. I tried to clip reconstruct, and most times you get away with it. This one I never. And she reoccurred, and she ruptured. And the post-op angio is great. And angio 9 months ago was just like 3 times the same size and all that. So before that case, I would just do either interposition graft or a radial artery, interposition radial graft. I wouldn't do a flow divert in this situation. I think you guys are probably more experienced about that than I would. But one thing I won't do is the clip reconstruction, I would have done early on.
Okay, Eva and Bobby, tell us what you're thinking, Bobby, and so forth, and what.
Yeah, so, we considered some of the stuff that the expert panelists were talking about. And so kind of like what Dr. Britz was saying about the clip reconstruction, we didn't think it would really be a good option because you'd have to place 360-degree, clips around the aneurysm to try to reconstruct the lumen, and it would have a high chance of recurrence. And then, the second surgical option that we considered was trapping and bypassing, which was, what we thought was a pretty good option and what we're leaning towards because she's young and it had the highest chance of obliteration. But the only disadvantage was that you would have to have temporary ischemia to the dominant left temporal lobe while you're stitching in the graft. And, but the patient didn't want any sort of craniotomy. And so she only wanted endovascular approaches. And so, to go through some of the endovascular approaches we thought about, we were thinking that for stent coiling, it wouldn't really be a good option for this case because you would have to coil it very densely, which would lead to mass effect on the dominant temporal lobe. And then it always also has a higher chance of recurrence. And so we also thought about possibly just doing a flow diverting stent alone. But we thought that with this, you would have to have multiple overlapping stents and need at least like 2 to 3 stents. And the advantages of this is, if the aneurysm doesn't die with the initial stents, you can always come back and place more. But, the disadvantage is that it's off label. And then there's still, even with multiple overlapping, there's a high chance of recurrence. And so we thought that the best option would be flow diverting stent with loose coiling because it had a higher chance of obliteration than just doing this flow diverting stent alone. And so here,
I guess one thing before you go to the next slides, I think trapping and bypass are a reasonable option for this, except for its left side, you're going to have temporary ischemia. She 100% had already seen multiple people, and she said, there's no way anyone's making a decision in my head. She said, I want to have a treatment and I want to be back to work on Monday, which is,
did she talk to Jacques? Did she have a conversation with Jacques?
She would have had a bypass if she had talked to me, but that's okay.
Exactly. She needed an eloquent person to talk to her.
Yeah. And so, and the one other thing about just pipeline alone, which we didn't really maybe see too clearly on the initial angio or the MRI, there is a part of this that's partially thrombosed in the superior aspect of it. And I think when you flow divert those cases alone, when there is some partial thrombosis in it, you're more likely to get into a potential failure situation where you still have slow flow in and you have growing thrombus. So in the end, we decided to do JL a microcatheter. We did flow diverting stent, and there's loose coiling.
Yeah, so these are the images like what Dr. Stark was talking about. So this middle image here is MCA down the barrel MCA view. So initially we placed the stent, the flow diverting stent here. And so here the white arrows show where the stent begins and ends. And so even with the pipeline in place, we already see there's some flow reduction in the aneurysm, and there's already some stagnant flow that we see already. And so, we're thinking that with normally when we place pipeline stents with like sidewall aneurysms, this is the kind of look that we're looking for. And so when you see this kind of stagnation, you think that the aneurysm will go away, but because this is a fusiform aneurysm, we thought that this just plating a flow diverting stent alone probably wouldn't obliterate the aneurysm. And so here, this view is important because it shows that whenever you place the coils, that the stent's not being compressed by the coils, and that there are no stents, like there's no coil herniating into the stent. And so here, this image shows the lateral, shows that the aneurysm's almost completely obliterated and the inflow and outflow is patent.
Is there any thought to putting in, like, let's say 2 or 3 flow diverters? Because when we did puffs, many of the giant cavernous aneurysms were, fusiform aneurysms like this. And, in puffs, the average number of flow diverters was 3. The other issue with the coils is that it does create significant susceptibility artifact if you want to image it non-invasively. But did you guys?
And actually, mine, I actually saw her twice before I treated her, and I documented a note that said all of those things. So option 4 or 3 was, 2 to 3 overlapping flow diverting stents. If the vessel was too small to jail a second microcatheter, if that proximal M2 is smaller, then I probably would have just done overlapping flow diverting stents, but I would have done at least probably 2, probably 3.
At least 2, probably 3. That's why. Okay, very good.
So yeah, this is the 8-month post-op angiogram, and so this is again the MCA down the barrel MCA view. This is the lateral view, and it looks like the aneurysm's pretty much almost gone at this point. And then she just followed up with us for her 2-year post-op visit. She's doing very well. The aneurysm doesn't look like it's recurred.
It's a nice, very nice angiographic result.
This is a lady that, she was treated on Thursday, home on Friday. She was at work on Monday, and I think a bypass and a sacrifice is has a higher obliteration rate, but, of course, for this case, it's also more invasive and probably has a higher risk profile also.
Bobby, that's a great case. I was quite surprised that you're going to show that 9-month angio looking like it did, because I think that, much like Henry said, for these fusiform aneurysms, the results aren't that great with a single flow diverter. I'm impressed. I never thought you're going to get that.
I agree 100%. This definitely not one flow diverter. This is probably going to be 3 if you're not going to. We've had some that are really small, and the problem is you can't jail a second microcatheter because there's not enough room. And we've done multiple overlapping, and I think Pascal's paper has a nice one on dissecting aneurysms with that. But, I agree. I think bypass not unreasonable for this case also.
Very nice. Only 2 questions left before I let everybody go. Henry, since you've always given thoughts about hemodynamics, why don't I ask you what Dr. Alim Bayramov is asking? Why does the circle of Willis, why is it the most common site for aneurysms?
I think that obviously the clearest, most sort of pathophysiologic answer is that you have more wall shear stress, at bifurcations. And so most aneurysms occur at bifurcations, at the MCA bifurcation, in the anterior communicating artery, PCOMs, many times there's a large PCOM that occurs, ICA terminus. And so I think that one of the major things with computational fluid dynamics, and we're doing a lot of work with Ann Roberts and Juan Sobral at University of Pittsburgh and George Mason University. And I think that it's probably wall shear stress, and that's why it occurs in particular locations. But I don't think we have a definitive answer why, at least not yet.
Yeah. Pascal, Dr. Mohammed Nabil Mahmoud, what do you think about the Medina coils?
So you know, Medtronic bought Medina and they killed it. It's not going anywhere. Medina is a little bit what I showed the Citadel, which is leaflets of coils. Medina was much wider leaflets. It was advertised being like an intrasaccular flow diverter, but this was part of some Medtronic went on a spree of buying and killing products like Artis, which is like the web, and like Medina, and then people got fired actually for that from Medtronic. So
and they bought Chestnut and Pipeline and killed the alligator.
That's right. Yeah, that's right. Yeah. So yeah, I mean, now with the Citadel, the trial just started. We'll see if it's gonna be something of interest. We don't know yet. So.
All right, it's 7 o'clock. Any last minute jokes or attacks or anything?
Yeah, so Jock, I'm going to ask you one question. Of the panelists, who truly has a butler at home? It's not me and not Pascal. I wonder who that is. I mean, I've been serious. This panelist has a true butler. Can you believe it? Henry?
I don't know, Gavin. I don't know what you're doing with your butler over in Houston.
He's denied it.
Definitely a lot less.
Jock, he has a butler at home.
What you're talking about?
No, he knows exactly.
All right.
All
On
right.
this marvelous end note, this was really both enjoyable, instructive. The audience stayed with us till the end. I thank you all. It was a last minute arrangement from last week, and I knew I was inviting some winners here. So thank you all for coming. Eva, David, thank you so much.
John,
Bye, everybody.
thank you. I try to come every Thursday. It's very difficult because it is my office hours, but I try to make it all the time. And thank you for putting all this together.
Thanks, guys.
I do office hours on Thursdays too.
Yeah. Take care.